Well, while Capital's getting set up, and we'll sort of flicker between sharing screen and not sharing screen, I'll just give you a quick introduction to IAPHL and SAPICS as well, for those of you who don't know us. So my name's Jenny Froome, and I represent a company, an organization here in Kenya called SAPICS, and we're the professional body for supply chain management. And we've been going for a long time anyway, 55 years. And 2 years ago, we started discussions with IAPHL, which is the International Association of Public Health Logisticians, with a view to trying to reactivate and re-energize the South Africa chapter, because we felt that there is a real need for a community for public health practitioners, supply chain practitioners, to have somewhere where they can go to meet other people, learn from other people's experiences, and generally just be in a group of like-minded individuals. And whilst we can easily say, you know, supply chain practitioners are supply chain practitioners, you don't need special groups. I think that when it comes to public health, I think that there are so many challenges, nuances and things that are so specific to this particular sector of supply chain practitioners that it's really, really, really important. However, I'm also learning, the more I sit in and learn about public health supply chain systems, that really private sector and public sector have so much to give to each other. And this is where the sort of the penny dropped, and it was an opportunity I felt that SAPICS and its predominantly private sector supply chain practitioners could actually work with an organization like IAPHL to really give supply chain practitioners a community. IAPHL itself it has over 8,500 members. It has 21 different chapters in countries all around the world, not just Africa, although the majority of the chapters are in Africa. I think Yukabeth is here. She represents the chapter in Kenya, I think I'm right in saying. And lots of us are new, lots of us are trying to get the communities going. And I'm a great believer in collaboration and doing stuff together. And so you'll see, we all know Ethiopia is not in South Africa, but I think it's really important that we learn from each other and that we can really just give support. And I want to give a real personal, professional thank you to every single public health practitioner that is in this room today. Because what you guys have been through in the last 18 months kind of puts what we've been through into a cocktail. I think that the challenges that we've all experienced are extraordinary, but the fact that people like yourselves who are working in the public health space and supply chain professionals in general can keep the world turning the way that it is, instead of sort of stuttering and stopping and starting, is testament to how brilliant you all are. So I felt that the topic today was something that was really important, because all the while that COVID is going on, and my thoughts are with everybody who has family or friends who have succumbed or suffered from this revolting virus that must just please go away. There's still all the other diseases that have been plaguing our lives or our loved ones. Cancer being one of those diseases. And when you stop and you start to think about all the supply chains that have been disrupted, if you think about the medical supply chains that have been disrupted because everybody's focus has been on COVID and how we can get the vaccine rollout done and how we can get this, what about all the other activities that need to carry on? Nothing's changed in that regard. So we brought Capital volunteered to speak at a conference, our conference that we're doing in 3 weeks time, and 2.5 weeks time, and I hope everybody's going to find out more, and Claire can hopefully put the link to the conference into the chat for later on. But I felt that this is such an important topic and something that we don't normally think about, and our traditional membership base doesn't normally think about. So we invited Capital to do this webinar on its own, independently of the conference, and not get lost in the noise, a good noise, but the noise of the conference. So I'm really chuffed to be able to invite Capital here all the way from, where are you in Ethiopia? Are you in Addis?
Yes, I'm in Addis, in the capital.
Addis with the smart new airport, thank goodness.
Yes, that's true.
So welcome and thank you for coming all the way to South Africa. Isn't that a joy for us? That's a COVID silver lining, is how adept we have become in our online lives, and it gives us the opportunity to be able to interact with all of you from around the various different countries. Cindy was just reading out to me all the various countries from Jordan to Ethiopia that we've got joining us today. Capital is a experienced supply chain professional working for the Ethiopian, what is it? The Ethiopian Public Health, now I've lost it, I had it all written down. The
Pharmaceuticals Supply Agency.
Thank you very much. I was so excited when I read your bio about the fact that you were president of the Pharmacy Students Association, that I kind of lost track of where you are now, because for me, you understand the value of associations, and you understand the importance of organizations like IAPHL and like SAPICS and the communities that we build. So thank you very much for giving your time and for preparing this, and we really look forward to learning lots from you. And from Toronto. Absolutely. So from all over the world, we're really delighted to have you all here. So Capital, if you'd like to take it away, and then please don't be shy about questions. We're going to leave some time for questions at the end. So you're very welcome, while Capital's talking, if there's something that inspires you or you're pondering on, please just drop it in the chat, and then I'll monitor that. You don't need to worry about it, Capital. You concentrate on your presentation. And then we'll do the questions after he's finished. So over to you, and thank you again.
Okay, thank you so much. I was about to say good afternoon, everybody, but maybe it might not be good afternoon for you guys. Now it is 10 p.m. in Ethiopia, and I'm so happy and I'm so delighted to have you all in this webinar. I was seeing the participants list. We do have a lot of participants from different disciplines. We do have warehousing and inventory management professionals, quality assurance officers, pharmacists, and project managers, and senior research scientists, and a lot of disciplines are joining in this webinar, and I'm so delighted to have you all here. And I want to thank also SAPICS for creating such a platform for us to share and to gain different perspectives of supply chain practice all over the world, and also in Africa. So it means a lot for us to gain and to share a lot of experiences with our professional colleagues and partners. So from directly jumping to my presentation, I would like to introduce myself. My name is Capital Berhanu, and I am a pharmacist and a marketing management professional. And currently I am doing my master's in logistics and supply chain management. And also I am a member of APEX and enrolled to CSCP international certification. And I was also a president of Mekelle University Pharmacy Students Association. And this is a little brief about my personality and experience. I hope it is enough. So as you can see from the title, today I am going to discuss and present about chemotherapy supply chain in Ethiopia. I believe most of you are excited to hear about the pointers which will be raised in this webinar. As you all know, the chemotherapy or things related with cancer are very alarming all over the world. So that's why I chose this area to present and share what is the supply chain of chemotherapy in Ethiopia looks like. So I will directly proceed to the outlines. So as you can see from the slides, we do have a short and brief elaborations on those topics. So we will start with the global cancer prevalence, the cancer statistics, the burden, and we will try to see some researches, and again the risk of supply chain management. And when we proceed to the next part, we will see the introduction to EPSA, Ethiopian Pharmaceuticals Supply Agency, and cancer care in Ethiopia, and EPSA chemotherapy products distribution system. And the last one will be the progresses and the challenges. Additionally, the recommendations will be my last points of presentation. I try to make the presentation content to be to give you a picture, the overall picture, and that's why I tried to include starting from the prevalence, the statistics, the researches. All those things are directly related with supply chain practices, and they are directly affecting and impacting our chemotherapy supply chain management process. So when we start, when we see the statistics at a glance, we start with cancer types, which are found all over the world. And the higher and the leading one is breast cancer, which shares 11.7% all over the world. And the second one is lung cancer, about 11.4%. You can also see the numbers. And also the third one is colorectal cancer, and prostate, stomach, and so on. And we do have different cancer types. So we will only try to emphasize the major cancer types are described here. So we have used the data source from Globacan and WHO, because regarding data related with chemotherapy, the most reliable and trusted data source are collected from Globacan. That's why I used the reference. So when we see the continental statistics, we see Oceania, Latin America, North America. You see a large number of cancer cases also in Asia. When we see in Africa, we see the cases, the share is around 5.7%. So I hope we will all have some questions regarding this prevalence rates in intercontinental statuses. So again, when we proceed to Africa statistics to our continent, the estimated number of cases in 2020, all cancers, both sex and all ages, we see Egypt taking the highest number of cases in Africa, and followed by Nigeria and South Africa. And when we come to Ethiopia, we do have 7% of share of cancer cases in Africa. So I think these numbers and these graphs and pie charts will give us the overall estimates and the overall prevalence of cancer cases, how much it is progressing and how much it is coming nearer to us. And are we just going to act, or are we just going to see? So when we specifically say these Ethiopian cases, we see the number of cases, new cases in Ethiopia. Yearly, we do have the highest number still. We have seen it in the worldwide number. Again, it is breast cancer, also the same scenario in Ethiopia. And followed by cervical cancer, which accounts about 9.6%, and colorectal cancer, and followed by leukemia. So I'm just trying to show you the prevalence and the numbers. So here we we are going to see the incidence versus mortality comparison. As you can see, the blue ones shows the incidence, and the red graph shows the mortality. When we start from breast cancer, we can see 41.5% incidence, and the mortality is 24.1%. So maybe it would be great if someone could reflect some points on this graph. What can you see and what can you understand from this graph? Maybe I can give some participants a chance to discuss and to reflect some points.
Has any got any observations?
So any participant who want to reflect on these graphs, what this graph show us, what did you understand from this graph?
Can I talk? My name is Yared.
Yes, Yared, you're welcome.
Thank you very much, Capital, for the introducing the prevalence of cancer worldwide and in Africa, and specifically in Ethiopia as well. Well, actually, what I can say is that, first of all, most of the numbers or the assumptions that are made in regards to cancer, specifically in the context of Ethiopia, is mainly an assumption. It's not a very exact number because since in Ethiopia, I am an Ethiopian, and I can say that we have got a very limited areas of cancer registration in the country. But taking this small number and expanding it in great, and from our experience, the predominant type of cancer that is mainly affecting females, the breast cancer, followed by cervical, and followed by ovarian. Well, these cancers are very interesting because breast cancer can be early detected, cervical cancer can be screened and you can stop the death. Ovarian also can be detected early. So this shows that preventable cancers are killing most of the people worldwide, and the access to chemotherapy of this type of disease is very complex because the presentation or the patients appear to the medical facilities in advanced stage, and more or less, the chemotherapy is changed into palliative care. So we should take into consideration this. So thank you for sharing this, but these are more or less preventable cancers that can be prevented. One is early diagnosed, the other one by doing a cervical cancer screening, you can prevent days. So that's what I am understanding. Thank you, Capital.
Okay, Dr. Arir, what can you also see regarding comparing the incidence and the mortality? When we see for breast cancer.
Yeah, for example, if you take the mortality rate, it's 24.1 and the incidence is 41.5. So, most of the cases, like if we say 40 patients have been seen or have contracted breast cancer, literally 50% of them, they will die in the first 1 or 2 years.
Definitely.
So you are just challenging my knowledge in the understanding of.
No.
Thank you very much.
Thank you so much, Dr. Arir. So any participant additional short reflections? No? So thank you so much, Dr. Yared, for sharing us and briefing the graphs. So Dr. Yared have already expressed the major cases which are impacting nationwide and worldwide are, most of the cases are preventable cancer cases. But when we see also the graphs you have also expressed, almost half of the incidence, there is half chance of mortality. So the number is very huge and it is very alarming. So as Dr. Yared have said, these cancers are preventable. So after the incidence, and even there are treatment options, but as we see in Ethiopia, the mortality rate is very high. When we see cervix, it's almost the same. Again, even when you see thyroid cancer, lung cancer, even when you see lung cancer, it is almost, the incidence is similar, almost equal to the mortality rate. And this is so alarming. And this will give us the eagerness and the energy if we could act, and if we commit some things, and if we invest in this area, we could promote and prevent such scenarios. So when we see the burden of cancer, I just try to pinpoint some points, and I start with the myths about cancer. And myths about cancer, when we go to facilities and when we visit facilities and when we even see patients and their relatives, the myths about cancer in Ethiopia is very difficult. It is mostly related with devil sent disease, and it is considered as a death sentence. So having such myths and perceptions, it is a huge burden in the treatment, also in the supply chain. And the other thing is the total treatment cost, not only the total treatment cost, even the unit price cost of cancer treatment medications are very high, and they are not bearable by our society. So that is the other difficult task which we are trying to fight. So the other thing is also the delay in diagnosis. We have tried to see in the graphs the incidence rate and the mortality rate, and even Dr. Yared have mentioned most of the cases are preventable. So in our case, even in Ethiopia, most of the patients came when they are on stage 2 or on stage 3 or stage 4. They came on late stages, which makes it difficult for the management and also the treatment. And the other thing is, which should not be neglected, is treatment of side effects and palliative care. Treatment of side effect and palliative care is almost equally important as managing the disease. Most of the patients, most of researchers also support that the treatment side effects are very dangerous side effects, so it should be managed together with management. So the other thing is the awareness issue. When we talk about the awareness issue, previously I tried to mention about the community perception. Not only the community perception, even in our health professionals, there is misunderstanding and some lack of knowledge and skills in the area. Actually, since cancer is almost a new case progressing in our country, and we don't have even enough professionals and health professionals, nurses, pharmacists practicing in that area. So I think that's also one burden for managing a cancer, which will directly related with the supply chain. So the next thing is we will try to see researches which are related with cancer, but those research findings will directly impact our supply chain process. So when we see after the new cancer medicines have helped to cut the overall cancer death rate by 20% since its peaks. So when we see since the beginning of war on cancer in 1970s, 5-year survival rate has increased 21% for breast cancer and 50% for prostate cancer. 36% for colon cancer and 54% for lung cancer. So as you can see from the study findings, even the survival rates are increasing, and if we could manage to improve the healthcare and the supply chain efficiency, we have a lot to provide for cancer patients. So risks with chemotherapy management, chemotherapy supply chain management, oncology drugs are clearly have become a target for pharmaceutical crimes. And we have also some falsified oncology drugs found, and it is the fifth ranked drug category, which is falsified. And this is a report received from the Pharmaceutical Security Institute. And the other thing is we have also witnessed some quality compromised products. Substandard cisplatin was found while screening of anti-cancer drugs in Addis Ababa, Ethiopia. When we proceed, we will move to a risk and theft and pilferage risk of these anti-cancer products. And when we see, starting from the number one, ophthalmic, neurological, sedatives, and we do have antiretrovirals, hormones, immunosuppressive, oncology products are the one which are liable for theft and pilferage. And this is one burden, again, in the supply chain sector. On the other hand, we are working to avail the products. On the other hand, there is another challenge of theft and pilferage. So I hope this gives us a good input in the supply chain practice. So I hope the things have given you an overview of cancer prevalence and related with cancer supply chain. So this will give us the bigger picture, and we will directly move to the supply chain practice, what the supply chain practices really looks like in Ethiopia. And how it looks like. So we will proceed to the overview of Ethiopian Pharmaceutical Supply Agency. Ethiopian Pharmaceutical Supply Agency is a legal entity established under the law of federal government, and which is established to overcome the problems and to assure uninterrupted supply of pharmaceuticals to the public at an affordable price. This agency currently is only supplying products for only public health facilities. And it is with a mission of ensuring sustainable supply of quality assured pharmaceuticals with an affordable price through committed demand, pooled procurement, and robust inventory management. So these are just an introduction, a short introduction about EPSA. I hope it is enough. So maybe before progressing into the next stage, maybe if you have some reflections, I may give a chance. Any participant who want to express or reflect some points on the previously pinpointed areas?
Yeah, so Josfat has just shared that in Kenya they spend close to $482, I guess, billion dollars to import drugs, 80% of which come from India. And ironically, we spend close to 89 million euros on travel to India for cancer treatment. What specific supply chain strategies can be used to reverse this trend or improve access to oncology treatment in Africa? So you can reflect on that, and I'll repeat that question towards the end. But it does go back to that niggle the whole time, is that we can't produce these drugs in Africa, and that has got to change. And we know that with COVID, that is going to slightly change, but that's just a drop in the ocean. But thanks for that, and we'll go back to that, Josephat. But I think that one of the things that struck me, and I'm sure you're probably all reeling from it, although seasoned professionals won't be as surprised as me, but I'm horrified by the theft. I just, it baffles me, and I think it reminds me how naive I am as to what goes on with insecure supply chains.
Okay, thank you so much, Jenny. Annie, I will give only one participant a short reflections, please. So, if you don't have points to reflect, you can reflect it at the end of the presentation, so I can continue.
Great.
So when we see the EPSA, 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 I think you will not misunderstood me. EPSA is Ethiopian Pharmaceuticals Supply Agency. So I will not say, I will say EPSA from now on. So when we see the EPSA supply chain process, it starts with product selection, and EPSA have already selected which products should be supplied to the public, because we do have thousands of drugs. So we might not be able to supply all the drugs to the country. So strategically, we have decided to have a procurement list, and we have selected products which will address majority of the publics. So we proceed to a quantification. So almost, as you can see from the PowerPoint, the supply chain process is not different. Maybe, if I'm not mistaken, it's not different from most of the countries. This is the almost worldwide scenario. So it will be, the quantification will be next. After the quantification, using the quantification data, we will proceed to procurement, and the procurement drugs will come to our warehouses. From our warehouses, the distribution process will follow, and the product distribution will be to our health facilities, so until to the end user. So when we see where are we currently, EPSA, we have 19 branches. Two branches are found in Addis Ababa, and the rest of the branches are found in regions. So we have 19 branches. From out of the 19 hubs, we supply chemotherapy drugs in 10 hubs. So from the 19 hubs, we distribute chemotherapy drugs using only 10 hubs. So this also shows us how much EPSA is giving emphasis to this chemotherapy drugs to provide access for our patients. So when we see the cancer care in Ethiopia, in a short and brief description, Black Lion Hospital was the first and the largest public hospital serving cancer patients in Ethiopia. And currently, we do have 16 facilities in different regions providing the service, and cancer medicines are distributed in 10 hubs of EPSA. And other thing is, even with the Ministry of Health and with the support of our partners and with EPSA, we are planning to expand the service delivery. We are planning to expand expansion. We have also expansion plans. And the next thing is, due emphasis is given by the Ministry of Health and EPSA for this chemotherapy and anti-cancer program. So the leadership knows how much it is impactful to work on this anti-cancer products and cancer management. So when we see our chemotherapy cancer centers in Ethiopia, the first one is TASH. in Amharic it is ጥቁር አንበሳ or Black Lion Hospital.
Hello? Oh.
Black Lion Hospital, and again we do have St. Paul Hospital, Urabe Hospital. As you can see, from our catchment hubs, on the first one, we do have Black Lion Hospital, which is found in Addis Ababa one. We do have also Adama Hospital in Adama, which is found in Oromia. We do have Hawassa Hospital, which is found in Isadama region, Wolaita in SNNP region. And at least we are trying to address and to increase access of availability of the products by expanding the oncology service providing facilities all over Ethiopia. So we do have some mid-term seniority hospitals and newly joined hospitals. For example, Warabe Hospital is a newly joined hospital. And again, we do also Asala, we have newly joined hospitals. So we have a senior hospitals and we do have middle term hospitals and newly beginning cancer oncology service hospitals. So when we jump deep to the supply chain operation processes in Ethiopia and in EPSA, I have tried to touch it in the cycle of supply chain previously. So we will start with forecasting, quantification, and market shipping. So we will receive the annual demand of health facilities. We will receive annual demand from all the 16 cancer providing health facilities, and we will aggregate the annual demand of the health facility. And also we will use our own EPSA transaction data. We have different data. We have distribution data, we have inventory data. So we will also use our transaction data. And again, we will also consider the product's expiry history, which will also give us a good input on forecasting and quantification of anti-cancer products. And we are also practicing morbidity data and consumption data. So the forecasting and the quantification will be reconciled. The morbidity data and the consumption data will be reconciled. We will prepare a workshop and we will call necessary stakeholders, our senior physicians, pharmacists from the facilities. So after we have finished the analysis and the aggregation of the data, we will discuss on the results. And we will reconcile our morbidity data results and consumption data results. Mostly our morbidity data results are a bit higher, and when we compare it with our consumption data. So we need to reconcile with the morbidity data results and the consumption record data. So after reconciling, we will decide how much is needed, what will be procured for the coming years, for the coming months. So that we will use this data even for replenishments of facilities. After we finish that process, we will proceed to a supply planning using those data as an input. We will prepare our supply planning, which product should be supplied, when it should be supplied, and in which way it should be supplied. We will prepare a supply plan. After we have finished, we will proceed to a procurement and contract management directorate. The procurement and contract directorate will receive an order from forecasting and quantification what should be bought. So the procurement department will analyze the budget and will validate the procurement requests sent or forwarded from forecasting and quantification team. Then the procurement directorate or department will do all the tendering process. I will not just go deep in detail because I don't think it is such important. So the other thing is the contract agreement will be signed, and the next step will be following the shipments. So during these processes, you may think what is different from other products. The thing what is different is we will use over the wall approach here. We will do the forecasting and quantification together. the forecasting department, and the WIM, or inventory management department, procurement department, we all sit together. We will not just come at the end of the result. We will do it together, and we will validate all the processes. Then things will be much more secured and cleared. Then we will proceed to the next step. So our total operation process is over the wall approach, and we will work together on those data. So when we see the outbound operations, and this is the operation which will directly link to our facilities, and we do have a warehousing and inventory management department, and after the contract is signed and shipped, we will receive the products with validation and costing, and the inventory optimization processes. The inventory analysis is done monthly for chemotherapy products, and we receive the inventory management team is the one responsible for receiving facility orders and responding to facility orders. So after completing those processes, we will directly proceed to distribution and fleet management. So the distribution team will plan ahead of time to distribute the prepared orders, and we use a monthly schedule. We will reach facilities monthly. We have different schedule. Maybe for Dase we have different schedule. For Adama we have different schedule. So we will deliver the products as per schedule and route. So the other thing is in distribution department, the volume estimation will be done, and follow up on product on time delivery will be conducted in this department. So I hope I try to show you and to give you some brief total process of our supply chain processes and how we are functioning. Maybe I hope it is enough for this webinar. So the other thing is we do have a national anti-cancer technical working group, and this national anti-cancer technical working group was composed of the team composition will a facility oncology head and facility pharmacy heads. We do have hub focals, head office focals, and higher officials from both inbound and outbound. And this is the team composition of our national anti-cancer technical working group, and it have scope and functions. We during the technical working group meeting, we will review the national stock status, identify action points, follow action plans, execute decisions, and create integration. So this national anti-cancer technical working group, I hope you may also take it as a good experience in your country, because it will support you and facilitate and give leadership awareness about what is going on regarding about cancer. So this National Anti-Cancer Technical Working Group is very vital in the cancer supply chain, because whenever if there are any challenges, the leadership knows and the decisions will not be delayed. The responses will be facilitated. So the National Technical Working Group is the one thing which we consider it is very vital and which we should keep strengthening. So when we see the...
Sorry, Capital, I was just going to ask, is the working group, is it a government initiative?
How did you say, Jenny?
The working group that you've just talked about, the cancer working group, is it a government initiative?
Yes, it is a government initiative. So as I have said, we do have team compositions. We have included the major facilities like Black Lion, St. Paul hospitals, and pharmacy heads, and from we do have hub focals from different regions. We also, and from head office, we do have specifically designated chemotherapy focals. So from the inbound directorate and the outbound directorate, from also the leadership, these are the team. And one thing I have forgotten here is we do also have a Ministry of Health. in the team composition. In the technical working group, we do have also a Ministry of Health cancer program teams, and also additionally, we also have a consistent partner. CHAI is also working with CHAI team. Clinton Health Access is also a team member of this technical working group.
Because it's interesting in the questions, you know, Solomon asks, is there commitment from the Ministry of Health to fight against cancer? And then Colleen is also asking, does your supply chain need to include the government, the health department of the government? You know, are you obliged to include them? But I guess the two link, and if there is commitment from the government, you've got a good first step.
Yes, as per the questions, there is a good commitment both from Ministry of Health and from EPSA, and I have tried to mention it before. There is a special priority and special emphasis is given for these products. I will see some points later. I will touch it. So the commitment is good, but still it doesn't mean it is totally amazing. There are a lot of things which should be covered and addressed, because if this National Technical Working Group together with the ministry, the facilities, with EPSA, it will do a very fantastic job. But I'm not saying the technical working group is perfect and functioning well, but this is our practice, and I hope this is our top priority in strengthening the technical working group for efficient supply chain and chemotherapy products availability.
Maybe can I add?
Yes,
Jane? Yeah.
Yep.
I think the participants should be clear that Ethiopian Pharmaceutical Supply Agency is not an independent body, but it's part of the Ministry of Health. So mainly it's a government procurement agency. So I think that should be very clear, and it's supervised or administered by the Ministry of Health, though it's dealing with procurement of drugs. Yeah. So the Ethiopian Pharmaceutical Supply Agency and the Drug Administrative Control Authorities, these are the big institutions that are under the Ministry of Health, just to make it clear.
Yes, thank you. That's very good. Thank you. That's helped.
So any additional reflection or question which I did not address?
Yeah, one question. I think it would be interesting for the group and for me as well. When we talk about chemotherapy drugs, we were talking about qualities. Quality should not be compromised in regards to chemotherapy drugs, because the quality of the drugs will change the course of the clinical presentation or the disease. But we were talking about cisplatin and things like that, which do have less efficacy, which you use cisplatin in many different types of cancers. As a group, how do we understand what's quality? Because when we talk about quality, there are different things that we talk about, like SRA approved, FDA approved, and things like that. But when it comes to procurement procedure, this SRA approved or FDA approved drugs, the demand for in the African context is very few. For example, the amount of cisplatin that we are going to purchase for Ethiopia is very few in regards if you take to Europe. So even though we don't have the chance of bulk procurement, SRA approved drugs are not, the companies, they are not competing on the procurement or in the tender. So mainly we end up in cheap drugs. And when you talk about cheap in regards to cancer, their efficacy and their side effect is very high. Their side effects are very high because I have gone through these drugs. I used to treat patients, and you know, cisplatin that you have bought in Europe and the cisplatin that you procured locally in Ethiopia, you know, the side effects are very tremendous. So how are we going to address this? This is a very big question. Maybe it might not be answered in this session, but I think it's a takeaway message. Thank you very much.
Quality assurance, absolutely.
Okay, thank you so much, Dr. Eric. I think I've also mentioned it. His questions is a little bit of a wider concept, and which needs also a specifically detailed discussion on quality of chemotherapy products. So if we try to touch or reflect some points, it might take our time. So, but still, there is no compromise on quality of products. As an EPSA, we always try to procure the highest efficacy and quality products. So maybe within the procedures or within, as you have said, within the marketing options, some scenarios might happen. But I hope it will be also a question for all of us, which will be a good input even for other discussion points, other discussion webinars. So I will continue with anti-cancer procurement. And we do have anti-cancer procurement list in Ethiopia. And previously we have almost, we used to import a lot of products, almost around 100 line of items of chemotherapy products. And through time, we start making the products line of items concise, and we have already set our procurement list for public facilities. So the list will set a reference against which the agency's performance can be measured. And even the public facilities will know which products are supplied by EPSA, which products are not supplied by EPSA. So the road is clear. And when we see about the performance, EPSA will be measured on the product lists in our procurement list. So we have currently 52 line items being procured in EPSA. So facilities will know, and we are also aware that those 52 line items should be available for our facilities as much as possible. And the list will be revised every 2 years. And when we prepare the procurement list, we are not the only one who will prepare the procurement list. We will do it together with the ministry, the facilities, and our stakeholders and partners. And we will try to incorporate our senior health professionals to provide their input on deciding which products should be procured through EPSA. So now we are just going to pass to the point how we are distributing anti-cancer products throughout the nation. So previously I called it old distribution, or our previous distribution system. As you can see from the PowerPoint, facilities will submit requests and they'll report to the hubs. And hubs will consolidate, validate, and they will send their request to central EPSA. And central EPSA will receive an order from the hubs and will respond to hubs request. And central EPSA will replenish to the hubs and send the product to the hubs. And this is our previous distribution system. The communication is totally central, or head office team have no communication with the facilities. The communication is with hub and facilities. Hubs are the only who have direct communication and relation with facilities. Only EPSA will receive hubs order and sending and distributing the product to the hubs with central EPSA responsibilities. I hope it is clear. So when we see our new ordering process, we use central ordering process, central order processing for chemotherapy products. From our programs, we only use for anti-cancer products. Central ordering processing is only used for anti-cancer products. We do have a lot of programs. We do have HIV, TB programs. We do have RDF programs, so many programs, but the only program which we are currently working on central order processing is on anti-cancer products only. And the reason we choose central order processing is to give and to see all the processes in detail. And this shows that there is a head office or a central commitment to know what is happening, what is the supply chain process, what are the challenges, what are the gaps, directly to know from the facilities. So we designed this new central ordering processing. So orders will directly come from facilities to head office. But previously orders will come to the hub, and we will manage, head office team will manage hubs order, not facilities order. But in this system, facilities will directly send to head office oncology teams, and their orders will be received. So as we can see, facilities submit their RRF. RRF is their requisition and reporting format. Their requisition and reporting format. So they will send us with cancer type seen and their number of patients directly to central EPSA. Central EPSA focal will analyze their drug request and triangulate all the patient data, determine the quantity to supply for the hospital. So after we receive the requests from the facilities, we will process and respond to their order. And after responding to their order, we will send the product through hubs. It doesn't mean that even though the product is requested directly to head office, the product will be sent directly to facilities. Still, the product flow is through hubs, because we make it that way because all the financial transactions are managed through hubs. So the information, the reporting, and the product requests are directly through head office, and the product flow will be through hubs. And the hubs responsibility will be in the central ordering processing is just to confirm that the products are collected by the facilities, and they will aware and they will notify facilities their products have arrived, and they will facilitate the delivery. And that's their main role the hubs are playing currently. So changing to this central ordering processing have shown us a lot of things. We have learned, and we have created a good bond with the facilities, and it helps us to know the real challenge and the real problem to the end user. That makes us to work together with the pharmacy professionals, even the senior physicians in the facilities. So that also help us to improving the availability of products, even primarily when we compare the availability of products primarily and currently, there is a lot of improvement on product availability. Even the facilities witness our communication, our approach, and our commitment to improve the current product availabilities. So regarding the availabilities are being witnessed with the facilities. And,
so Capital, just to give you a quick time catch up, we are literally nearly out of time. So if there's any sort of wrap up points that you want to share, because I know that people are time constrained. So just to let you know that, and just to remind everybody, keep your questions going, because we can always answer them afterwards, and the recording is going to be sent out to everybody. So carry on until you're done, but I just wanted to give you that update because we're interested.
Okay. So we are almost done. I'm just going to continue on the progresses. So we have a good progress on subsidy and markup free. The Ministry of Health will subside 50% of the costs of anti-cancer products, and that is also a good experience. Even I think it could be shared with another countries. We are also planning even to make it totally free for the future cancer care. We are planning to product price totally free. So what we will grab in this point is we do have subsidy of 15%, and we have deducted the markup and the margins from chemotherapy products, which that will support our patients affordable, which will make products affordable. So currently we are progressing using the morbidity and consumption data, even though the morbidity data are not still clear and consistent. We do have a lot to work on this area. A cancer registry is also only in Addis Ababa, So the cancer registry should be established in regional satellites, in regional facilities. So without having a cancer registry and patient data, these things are very important in a cornerstone for the treatment, also for the supply chain process. So that is the point. When we see the challenges, we do have unpredictable demands. That is a major challenge in cancer. Sometimes it shoots up, sometimes it stops, the lead time, and we do have expiry and wastage problems also. And other things are almost related and touched in my previous discussion points. So when we see the recommendations, establishing system-based, now most of the facilities are using Excel and using paper. So we recommend establishing system-based national cancer registry even in regions, not only centrally. Inventory analysis should be strengthened, the morbidity data should be strengthened. And the other thing is distributed to selected Panama pharmacies. Panama pharmacies are public pharmacies, but they are open for private market. Private hospital patients can come and purchase products from Panama pharmacies. So we are also on the way to distribute the product to Panama pharmacies, not only to public hospital pharmacies. So we are also planning to devise a ways to address the private market, because we also have many facilities giving service on cancer. So we do have distribution tracking and control, and we have also restricted the markup and the margin in public facilities. Public facilities are not allowed to add or markup or margin in facilities. So that's also a good input. And the other thing, Jenny also mentioned it, we encourage local manufacturers to start producing in our country. And we do have even a park, pharmaceutical park, and which is open for our manufacturers. So it is because there are products which we know which can be manufactured and produced in Africa. So we can select those products and we can manufacture. So involving the leadership is continuously is very vital and important. And I hope this is my presentation. Overall, I hope you all have gained some perspective and a big picture of what the supply chain system looks like. Actually, the topic is very big, but I try to make it short and concise. So I hope we will have, because the anti-cancer topic is not well addressed. Well, so Jenny also, if you take this assignment, we have a lot of responsibilities to share and our experiences all over Africa, even all over the world. So thank you so much for giving me this time.
Thank you, really. It's fascinating, and you can see from the number of questions and the engagement, you're not aware of it in this sort of forum, but lots of people, you've got a lot of people thinking. There are a lot of questions. One of the questions that came through, which I think I know the answer to, but we talk about drugs, but is EPSA also responsible for the commodities? So all the other bits that are involved in actually being able to administer the cancer drugs.
Okay, Jenny, sorry, I didn't get your question.
Okay, so are you also responsible for the procurement of all the commodities around the administration of the cancer drugs, not just the drugs themselves?
Yeah, yes. I am. I was also the inventory management officer, which is directly related with facility orders. I am their cancer focal in head office, and again in procurement. Currently, I'm also working in procurement. So yeah. I'm the right person.
Big job. But also, you know, we haven't even touched on, and this is a topic for the next discussion, we haven't touched on the skills that are required. We haven't touched on the upskilling of individuals. And I'm so delighted to see that you're doing your CSCP, and that we can get doctors, professionals who've been tasked with this mammoth supply chain skill, and yet who receive little or no education about the best practices in how to achieve it. So again, that's a topic for another day, but it's a really important discussion. And there are a lot of countries' questions around that from a human input point of view, because at the end of the day, a supply chain is only as effective as the person who's managing it or the people who are managing it. And they need the skills to be able to do it. So one comment from Didier is, so proud of you. You're too young and you make your country very proud. So I hope that makes you feel good, Capital.
Yeah,
but
definitely.
But we'll definitely share the transcript so that you've got all the questions. And if you want to reach out to the people who have asked you questions for them to answer them specifically, we're very, very happy to provide that, you know, to be the conduit between, so that nobody goes without answers to their questions. Berhan, thank you very much for answering the questions that you could in the chat. That was really insightful. And to Dr. Yada, thank you very much for your input too. It was really, really interesting. So Capital, well done. Thank you. And thank you for being brave enough to take us up on our offer.
Okay, thank you so much. Thank you so much. I hope we will meet again.
Yeah, oh, I'm sure. Now we know you're not going to escape. We're very good at asking people for a small finger, and then we end up taking the whole arm. So you're not running away. And to all of you who are here today, please remember membership of IAPHL. There's no charge for it. So if you're not already a member of IAPHL, sign up. I put the link earlier in the thing. It's a wealth of information. Sometimes it gets quite noisy, but there's also all sorts of inputs that can help you from all over the world. So sign up for that. And then hopefully we can see you at our conference on the 24th to the 26th of August. It's going to be great. There is a small registration fee. It's really not a lot. We need to pay for our bread and butter too. So hopefully you will be able to join us. We look forward to seeing you there. But thank you for joining this one. And we will be putting forward a regular calendar for the IAPHL seminars, South Africa chapter. But also SAFEX has got a huge calendar of events. So keep your eye out there. Membership of SAFEX is a very small fee, but you get all these webinars for free. So have a look. And if you've got any questions, you can reach out to me or any of you can see all the SAFEX logos. There's a few of us here, but we're very easy to get hold of. But thank you very much. Safe travels back to wherever you've come from. And keep well, and thank you all so much for all that you're doing to keep us all healthy.
Okay, thank you so much. Thanks so much.
Take care, everybody. Thank you very much.
Okay, goodbye.